Good morning, everybody. Happy Wednesday morning for us here in Seattle and for all of you everywhere that you are. Hello. We're going to be talking today about POCUS and trauma. And our speaker, Dr. Raj Nathwani, will be signing on in about a minute or so, and then we'll be able to get started. Just a reminder that this is our last session of the academic year. So we're going to go out with a bang because Dr. Nathwani's talk is really amazing. And then we'll resume back in September with, I believe, Dr. Arti, Sarwal, who is going to be talking about trauma, talking about point of care ultrasound for neurocritically ill patients. And that is going to be an amazing talk. She's also a national leader in the field here in the United States. So if you have an opportunity, please make sure to pick back up with us in September. We'll make sure to send you emails so that you're aware of the lineup moving into next year. And we'll get started here in a second. Before we get started, does anyone have any questions, or have you had any issues using the link to log on? Great. Okay, well, that's good. No news is good news, I suppose. David, anything else you would like to add or say? This is my colleague, Dr. David Liston. He is over at Seattle Children's Hospital, a pediatric anesthesiologist who is very, very engaged and interested in global health and global medicine. David, if you have any comments, please feel free.
Yeah, and welcome everyone. Just happy to see such a global audience joining us this morning. Looks like we have 35 participants so far and counting. More every minute here. Yes, this has been a terrific collaboration. I hope it's been useful so far, and I think it will continue to as we cover a broad category of different subjects. It hopefully will be even more useful as we go, and we hope to have your participation. Potentially, we are always welcoming and hoping to have global speakers share their experience and allow us to collaborate in an educational fashion that's helpful for everyone involved. So we'll get started shortly as our speaker logs on, and we appreciate everyone's participation.
And I see Dr. Nathwani now. Dr. Nathwani, thank you so much for joining us this morning. While you're loading up your slides and sharing your screen, I just would like to give a brief little intro for Dr. Nathwani. Dr. Nathwani is one of our seasoned trauma anesthesiologists who works at Harborview Medical Center, which is our big trauma center. He trained in the UK and has had so much training and worked in so many different really amazing facilities all over the world that I won't do him justice by trying to wing it here. But I would just want to tell you that I'm just really honored to have him as a colleague. You're really going to enjoy this talk today on point of care ultrasound and trauma. And without any further ado, I'll hand it over to Dr. Nathwani.
David, Sarah, thank you. I'm sorry I'm running late. I can't seem to share my screen.
Oh, let me see if I can make you a co-host, and then maybe that will allow you to share your screen. Are you able to now?
Yes, I think so. Here we are.
Okay, perfect.
Okay, can everybody see my screen?
Yes.
Perfect. Okay, let's hope this works. So yes, this morning, thank you, Sarah, and thank you all of you for having me here. And I apologize for running late. The grand round was something that I have a particular interest in trauma and coagulopathy, and then that was running late, so I'm running late. So this morning I'm going to talk about ultrasound use in trauma, and I've said as simple as ABC because, as you'll see, really it's very useful for all bits of trauma management. Oh, I can't seem to move my screen. Oh, there we are. Right. So as Sarah said, yes, I'm British, but I'm now in the US. I've been here for 4 years. I did my residency in medicine, then anesthesia and crit care. That's kind of the standard pathway in the UK, but it does take you about 13 years to get from start of residency to getting to being attending. I did my trauma and critical care fellowships in Melbourne in 2014 to 16. I've got 3 boys and my wife does the brunt of the childcare, so I'm always indebted to her for that. My interests are the outdoor worlds, really. This mountain down here is the 14th highest peak in the world at 8,040 meters, Mount Shishapangma, and we try to ski off the top of that. In 2007, we got kind of snowed in at 7,500 meters. So one day, maybe I'll go back. And I've done 20 years with the UK military with active service in Afghanistan in 2010, and that's probably where my major interest in trauma comes from. And really, I'm indebted to all of you because I have learned a little bit, I think, about global healthcare when I spent 2 months in Zambia. And I hope I will get out there again at some point to do some teaching and learning. You always learn more when you go to another country than I seem to teach, but always a great experience. So today I'm going to talk about, oh, sorry, no financial disclosures on my part. The outline for this talk is we want to just have a look at why we're using ultrasound in trauma patients, and then I've got a couple of case discussions with some learning points at the end. I probably won't be able to keep an eye on the chat, but please, if anybody's got any burning questions, just interrupt and shout out so that I can try and make sure I'm making sense. The objectives for today, really, the EFAR scan is the main kind of utility for trauma. And hopefully that will give us an idea of what common pathologies can easily be ruled in and ruled out, and then how also this can be used in other perioperative patients. Okay, so if we start with airway, well, ATLS algorithms uses the kind of ABCD approach in its primary survey, and obviously in most places this is all done concurrently, but the reason we start with A is because that if there's a problem with your airway, that's probably going to kill you before something kills you from breathing, circulation, etc. Obviously, the caveats to that have changed with trauma warfare, and unfortunately, it probably should read CABCD now with catastrophic hemorrhage often coming above airway. But if we were to start with airway, then the real utility is that in trauma, obviously, our airway trauma can mean that the airway anatomy is grossly altered from injury or hematoma, making landmarks very difficult to feel. And if you do end up having to do a front of neck access, then this is where ultrasound can be super useful just to find where midline is. Okay, and for most of us it's kind of obvious that the airway is in the midline, but when you have a massive hematoma pushing your airway right over and then you fail to secure the airway in a standard manner, then putting a big incision down the middle of the neck is not going to be of any use because the airway is not there. And using ultrasound at least gives you an idea of where the trachea is sitting. And so this is typically done with a linear probe. And if we can scan both in the sagittal and the transverse plane, then we can get a good idea of where the cricothyroid membrane is. And often you'll be able to see a lot of the tracheal cartilages as well, all the way down. But really, as I say, if we're doing front of neck access, what this is really giving us is where is the airway sitting, so that I can at least start to make my incisions and try and get access to the cricothyroid membrane. And so if you're ever in this situation and time allows, then scanning pre-knife to skin is the way to go, and then just marking where your airway is. For those of you that do deal with trauma, you'll often find that patients who are peri-arrest have very poor end-tidal CO2 return. And so trying to use end-tidal CO2 as confirmation of where, when you have successful airway secure, is not always helpful. And then trying to listen to the chest for air entry becomes super difficult in a busy, loud ED where a trauma call is going on. And so real-time ultrasound, once again, a linear probe is good enough. Looking over the trachea and esophagus easily helps you identify if the tube is in the right hole. And several meta-analyses have been published over this showing very high sensitivity, around 99%, and specificity of around 97%. Now, having done this several times, I've got to say that it takes practice and really needs to be done in real time. If you intubate and then put your probe on, you'll find that it's sometimes difficult to identify where the tube is sitting unless you have a lot of experience. But doing it in real time whilst intubating is super useful, and easily you can tell you if there's an esophageal intubation. The other time that I find that it's very useful is when you're struggling to get your OG or your NG tube down. And once again, on the slide here, this is the esophagus here, and you'll be able to see if your NG or OG tube is going down the right way or not. And often that can be a difficult tube placement. I'm obviously not running through the intricacies of how to do airway ultrasound. I'm hoping that we'll have another day when we have lectures in detail on airway ultrasound. The other question that often appears is the patient safe enough to have sedation, or do we need to do an RSI? And, you know, it's very obvious when the trauma patient comes in an acute setting that they're probably going to need an RSI because there's always a risk that the stomach is going to be full. But it's these patients who are then starved overnight and they come in to have their elbow fixed the next day. Well, have they emptied their stomach or not? Even though the trauma was 12 hours ago and they haven't had anything to eat or drink, there's still a high risk post-trauma, post a lot of pain, post opiates, that their stomach hasn't emptied at all. And then, you know, if you want to try and do these procedures with an LMA or do a standard induction, then really we should know whether the stomach is full or empty. And gastric ultrasound has really been a game changer in this environment. The other patient that often presents is having limbs pulled either in the ED or in the pre-anesthesia area, where, you know, you're told that they just need a little bit of sedation so they can get this limb reduced, and then having an idea of how full the stomach is just absolutely essential, because if we do a deep sedation and the stomach is full, then you run the risk of aspiration. So gastric ultrasound, once again, is something that we need to practice. It takes probably about 50 scans to be able to clearly identify where the antrum is and whether it's full or empty and what's inside it. But once we've got this skill under our belt, then hopefully it will target whether these patients can be sedated, whether they can have a supraglottic airway device, or whether they need an RSI with a tube. The breathing side of things, I'm obviously the real big rule outs that we want to rule out pneumothoraces, and especially tension pneumothoraces. And looking for lung sliding is an absolute key skill that we need to be able to develop. But also, if we go a bit beyond this in trauma, lung ultrasound can be super useful to look for lung contusion. So I'm just going to, oh, sorry, there we are. So on the left-hand side of the screen, this is an example of a patient on ICU with lung contusion. And you note the kind of irregular pleural line that you can see, which is very common. They can also have B lines, which you can see here. So it gives us areas of focal contusions, and obviously if we're getting B lines everywhere, then maybe the pathology is different, but it's very useful for looking at that. The other thing that it can be useful for is looking for diaphragmatic thickening in spinal cord injury, and also looking for effusions and massive hemorrhage at the lung bases, which we'll come back to in a bit. The utility of ultrasound really in hemorrhage, however, has come mainly from looking for undifferentiated shock and working out where the problem is. And obviously, if a patient is shocked, then the risk of mortality goes up massively in trauma. And within the first 6 to 24 hours, hemorrhage is the leading cause of trauma death. And so we all know the adage of, you know, hypovolemia is caused by blood on the floor and 4 more. Well, the blood on the floor, hopefully you're noticing, but the other 4 areas of chest, abdo, pelvis, and long bones, well, ultrasound should be able to help you find the vast majority of those. So very useful for looking for hemorrhage in the trauma patient, but also differentiating the other types of shock. So we've also already talked about tension pneumothoraces easily being ruled out with ultrasound, but also ultrasound can help us easily identify tamponade as well. And then if that's not found, then really it's a rule out of neurogenic shock as well. With the increasing elderly population coming in as our trauma population, and many of our patients also coming in with comorbidities and substance misuse, then using ultrasound to differentiate the shock is even more useful. So the focus of assessment with sonography and trauma, or the FAST scan, is an ultrasound protocol developed to assess for hemoperitoneum and hemopericardium, and numerous studies have demonstrated sensitivities between 85 to 96% and specificities exceeding 98%. So a super useful tool. And in the subset of hypotensive trauma patients, the sensitivity of the FAST exam approaches somewhere around the 100% mark. So a very, very, very strong tool. And once you've got experience at doing this, you should easily be able to do a scan in less than 5 minutes. And its use decreases time to surgical intervention. It's been shown to decrease patient length of stay in the ED, and also decrease the rates of CT and DPL. And really, in a recent retrospective study, more than 96% of level 1 trauma centers in the US use the FAST scan as part of their trauma workup. So something that really we should have a good grasp on. And it's built into the ATLS algorithm. Traditionally, it was kind of made up of 4 views. So looking at the right upper quadrant, and when we're looking at the right upper quadrant, we want to look at kind of 3 main areas. The inferior pole of the kidney, near the caudal tip of the liver, is the most sensitive area and most likely area to show fluid accumulation. And then looking at Morrison's pouch, and then also the suprahepatic area between the diaphragm and the liver for fluid there. The subxiphoid view, looking for fluid around the heart and trying to rule out cardiac tamponade. The left upper quadrant, once again, showing 3 areas, so the suprasplenic area between the spleen and diaphragm, and then looking between the kidney and the spleen, and then once again looking at the inferior pole of the kidney and the pericolic gutter is very useful. And then finally looking down in the pelvis, just superior to the pubic symphysis. And obviously it's important to realize the differences between males and females and the normal structures that would be present. So in men, we're looking at the rectovesicular space, and in females, we're looking at the rectouterine pouch, also known as the pouch of Douglas, or in the vesico-uterine pouch posterior to the bladder. Down here, we've just got a male and female normal anatomy. So you've unfortunately got to do several of these scans to at least get a grasp of what is normal and how to get the views. Most of the scans are done using a curvilinear probe, just so that we can get deep enough penetration, and then aiming to start looking for fluid in these areas. The extended FAST, which has come about in probably the last 10 years, builds on this FAST algorithm to start looking at for other potential comorbidities. So the first bit is looking up at the chest to rule out pneumothorax. And once again, this can be done with your curvilinear probe, or you can go back to using a linear probe if you wanted. But if we looked a little bit further, then we can also once again get a little bit more information. So when we're looking at the subcostal view, we can have a look at the IVC and look at potential filling or central pressures from that. And when we're looking at the right upper quadrant and left upper quadrant, then having a look at the lung bases to rule out large effusions or hemothoraces is super useful. And as I mentioned, we can look at diaphragmatic thickening as well. Having tried to do this, I've got to say, diaphragmatic thickening is something that takes quite a lot of expertise and is, I find, quite difficult to do. But, you know, with enough scanning, it's something that we should all be able to pick up. For those of you on the call who don't deal with much trauma, you're probably asking, well, what's all the utility for me as a general anaesthetist? Well, you know, everything that I've just said can easily be extrapolated to the undifferentiated shock patient in general surgery or in general anesthesia or on the ICU. And there's several protocols that are out there looking at how we can use ultrasound in a very similar manner to rule out shock in the other patient. This is just one of those protocols. It's called the RUSH protocol, but there's several other ones out there. And you can see in this that they, apart from RUSH, the rapid ultrasound in systemic hypotension, or they kind of look at 5 main areas. So they're looking at the heart, the IVC, Morrison's pouch, aorta, and then pulmonary scanning, and they've given that the acronym of HIMAP. And so once again, we can start by looking at the heart, long axis, short axis, apical, and a subcostal view. When we look at the subcostal view, have a look at the IVC as well, and try and work out whether things are full or empty. Looking for the lung to rule out pneumothoraces, whether there's pulmonary edema, and whether there's effusions at the lung bases. And then when we get to the abdomen, looking for any free fluid in the abdomen, and also looking at the aorta to see if there's any dissection there, or if there's any aneurysm that could possibly be causing the shocked picture. And then finally looking at leg veins to rule out DVTs, and therefore potentially push us down the road of PEs. So if we can get good at scanning these simple areas, it will very rapidly be able to be used in the undifferentiated shock patient, wherever we see that patient, from the ED through to ICU. Ultrasound, is super useful in our ACLS protocols, looking at whether there's cardiac contractility and potentially the prognostic value of that. Well, similarly, in trauma, ultrasound is now being used to try and make decisions on whether there's any organized cardiac motion, given in this yellow box here, as to whether patients should be undergoing resuscitative thoracotomies in ED post-blunt trauma. And so this algorithm is very recent for us at Harborview. You can see here it just came out in February 2023. But once again, if patients are coming in very hypotensive or arrested, using ultrasound to look at the heart prior to undertaking a thoracotomy will hopefully save resources and save time as well. TE is somewhere where hopefully, as we all gain more expertise in this area, will be utilized more and more in trauma. Obviously, it gives us an ability to continuously monitor the patient during the operation, whilst TTE becomes often difficult when the surgeons have already scrubbed in and are opening both the chest and the abdomen. And really, we're just trying to get 4 simple views. So an upper esophageal short axis view, the mid-esophageal 4-chamber view, transgastric view, and then looking at the thoracic aorta is what we're aiming to do. Obviously, there are some contraindications for this. So if we think that there's esophageal injury or there's an unstable cervical spine injury, then putting a TE probe down could be difficult and probably shouldn't be done. But otherwise, really, if we're extrapolating data from the cardiac world, then this is a relatively safe procedure with very few intra-op complications, probably around 0.1, 0.2%. So something that can be done. And with the advent of disposable probes, it just enables us to potentially put a probe down in the ED, use it during the operative phase, and then the patient can take the same probe with them to the ICU and enable ongoing monitoring in the ICU using TE. And so let me just see if I can get these running. These are just some examples. And obviously, one of the big advantages of TE is it gives us generally great pictures, and much easier than trying to get views with a TTE probe. And so really in trauma, what we're trying to rule out are 4 main pathologies. Hypovolemia, so that's what you can see here, papillary muscles pretty much kissing, showing a empty LV in the transgastric short axis view. We're trying to rule out aortic injury. So this is an example of an aortic dissection with a tiny true lumen in the mid-esophageal inflow-outflow view. And also trying to look for tamponade So here we have the transgastric short axis view, and you can see that there's a lot of fluid around this heart, and the heart is tiny and struggling to fill. And then finally looking for pleural effusions and pneumothoraces. So these are the kind of things that TE very rapidly helps us rule out, and hopefully more units will be using this in the future. If we move on to, how can it be used for disability? Well, thankfully, a lot of us have easy access to CT scans, and most of our head trauma will have some kind of head imaging. But if either your CT scan is a long way away, or it's not easily available, then ultrasound once again can give us an idea of what ICPs are doing, and really provide us a window into the brain. Looking at the optic nerve sheath diameter is something that's easiest done with a linear probe. If you're doing this, then just bear in mind that the jelly that we use for scanning can sting if it ends up in people's eyes. So putting a tegaderm over the eye, then putting a lot of jelly on, and then using your probe to get a view is super useful. And there have been lots and lots of studies done on this. And really, if we look 3 millimeters behind the globe, anything with a diameter greater than 5 millimeters really is at high risk, and is very sensitive for high ICP. Obviously, it needs to be correlated with the clinical picture, but several studies have shown good sensitivity and specificity for high ICP with this. It's also useful in medical patients who we think could be at risk of high ICP. So, those kind of hepatic encephalopathy patients, this can be super useful as well. And then other types of more specialist ultrasound are also gaining traction with TBI. So tissue cranial Doppler is very commonly used. And there's an ongoing trial called the CUPID trial, which is aiming to look at intracranial hemorrhage via TCD. And also TCD can be used for measuring effective flow around your MCA and therefore blood pressure in the brain. So there are other utilities. I've got to say that TCD is a very specialist area and needs quite a lot of training before you can reproduce whether the imaging can be reproducible. So it's not something that I do, but looking for optic nerve sheath diameter is actually very simple, and something I would suggest you have a look at. And then finally, the utility of ultrasound and getting IV access. And obviously what we're trying to get short, fat, big lines in for trauma. And really ultrasound is super useful for making sure that we have good IV access, that there's no disruption in the veins that we're trying to put lines into. And in the past, a lot of people used to do their lines blind for trauma, but the Cochrane review in 2011 definitely shows that central line access is faster when we're using ultrasound, especially for internal jugular and femoral vein access, with less risk of arterial puncture and hematoma formation. And people often say, well, if the neck is not secured or hasn't been cleared from a trauma point of view, then how can we go into the right IJ? And what we'll end up doing is just taking the collar off, doing manual inline stabilization, and then using ultrasound to get into the right IJ. And there's really very minimal neck movement that's required to do this. The data is not so clear for subclavian lines, but I put it to you that it's something that you should probably practice doing with ultrasound. It's very easy to get a view. Here we are. So subclavian artery, subclavian vein here, and very easy to do that. And avoids that kind of digging around in the chest, getting worried that you're going to cause a pneumothorax, and enables us to get access pretty rapidly. For peripheral access, I mean, in the past, I can remember when I did ATLS for the first time about 20 years ago, we were all being taught how to do saphenous cut downs, and I haven't even seen a saphenous cut down in the last 10 years, and that's probably because most of us are getting very good at getting IV access using ultrasound, even if it's a relatively deep IV. Obviously, there is the risk of extravasation, and we need to bear that in mind and keep an eye on these, especially if we're hooking it up to high pressure devices like a level 1 transfuser or a Belmont. But it has meant that getting good IV access quickly is very easy now using ultrasound, and therefore the need for cut downs or IO access is definitely decreasing. So I've got a couple of cases in the last few minutes that hopefully just highlights some of the uses and also gets us to think about some of the pitfalls with some of our imaging that we will use. So the first case I had a few months ago, and it was a week of skiing injuries and broken noses and clavicles. And this was a 12-year-old previously fit and well male who came in. He was kind of normal size, about 38 kilos, 6 days ago, skiing in a terrain park, and had a pretty nasty fall with significant damage to the helmet. Didn't lose any consciousness. There were no lateralizing signs. Was taken to a hospital at the time and had a fractured skull on CT scan, had broken his nose, dented his ego pretty badly. But there were no other significant injuries. And so he'd come to us 6 days later to have his nose essentially reset. In the pre-op assessment area, mum said that as a child, when he'd had a circumcision, it'd taken him a long time to wake up. And then when we looked at him, he otherwise looked relatively fit, well, normal. His heart rate was a little bit high, but I just put that down to being anxious on the day of surgery. Blood pressure was fine. Normal mouth, lung, and cardiac exam. So we decided that we would just proceed with a very simple propofol fentanyl induction, used an LMA size 4, seated very nicely, using sevoflurane for maintenance. And this was like a 20-minute procedure. There was minimal blood loss. He was spontaneously breathing throughout. In the middle of the case, he ended up with a sinus brady, and one of my colleagues gave him some glycopyrrolate for that, which then left us with a heart rate around 150 plus. It was narrow complex and irregular tachycardia. I initially thought that it might be an SVT, so we tried some vagal maneuvers, but by that stage, the patient was coming to the end of surgery, so was coming to emergence. We decided that we would just wake him up. The LMA was removed, the heart rate was improving and was kind of down to 130 by the time we were moving around to POCUS, and blood pressure had never dipped, and he was otherwise stable. In the POCUS, his heart rate just seemed to remain high. It was kind of between 110 and 130 all the way through. It took him a very long time to fully awaken, like hours, given that he'd had a 20-minute procedure with minimal opiates and minimal long-acting agents. And he remained hypoxic. And so the question of, well, what we're going to do now? This was a kid that was meant to go home, half an hour after surgery, with no real other follow-up. And so the real question was coming up with, what would we do now? So what would people like to do? Or what are on the differentials? Are people able to shout out? Or do they not?
They should be able to. Just feel free to go ahead and unmute your microphone and ask questions.
I'd have a PE on my differential.
Okay, yeah, absolutely. Could be right. Yeah, absolutely. Yeah, polytrauma with high VTE risk, even though actually he didn't have any lower limb injuries, didn't have any chest or abdominal injuries, but yeah, absolutely could be. Yeah. And so what were you going to do to rule that in or out?
You could start with a like cardiac focus. Look
Yeah.
when he's had the right-sided strain.
Yeah, absolutely right. And given that this is a POCUS talk, that's exactly what we ended up doing. So we got the probe on, and so what view is this? Parasternal long, okay.
Yeah.
And so and if this was your heart, would you be happy or unhappy?
Unhappy.
Yeah, so what are we seeing?
The left ventricle is not contracting well.
Yeah, absolutely right. So at this point, I ended up getting a colleague because I was kind of a bit shocked that the LV was looking so bad in a 12-year-old who was otherwise an ASA1 patient. And I got a colleague just to come and have a look and say, am I seeing things or is this real? After which the patient had a formal echo, which also showed exactly the same thing. And so then we were in discussion with the pediatric ICU and the pediatric cardiac ICU, and the patient got transferred from us to the pediatric hospital. And this was all labeled as a stress cardiomyopathy. It could have been due to the stress of the GA, but given that it was a 20-minute procedure, I hope that wasn't the case, or more likely secondary to a TBI. He had a whole blanket of tests sent off and to try and rule out secondary causes of LV failure. Thankfully, all of them came back negative, and this resolved over a few days with no, as far as I know, no ongoing long-term sequelae. The only thing that I want to highlight here, so these are his short axis views, if we, let me just see if I can get this to play as well. So the important thing to realize is when we're looking at the short axis view is to try and slice through the heart at multiple areas, because this is a good example of where one area of the heart is actually contracting really, really well. And then if we just move down a tiny bit further, the other bit of the heart isn't. And it's very easy if we cut the heart at the wrong area to think actually contractility is fine when actually it's not. So just make sure that you know, when we're looking at bits of the heart, that we try and look in two different planes and in multiple areas to gain a better understanding of what's going on. And the second learning point is, for most of us who are not experts in any of these modalities, then when we think something's going wrong, then get a colleague to have a look, and if we think something is truly a problem, get a formal ultrasound or a formal study to look at that. So the next patient I have is a 66-year-old lady, known smoker with COPD, who had a ground level 4 with a traumatic C7T1 unstable fracture. She was thin but otherwise well kept, hypoxic, lying flat in bed at 90%, but no other gross neurological deficit. She had a scalp hematoma. On CT had rib fractures 3 to 7 on the right, but no flail, and otherwise nothing else on the trauma CT. So she was posted for a semi-elective PSIF. She underwent a TEVA anesthetic, had a normal airway, was proned. Intra-op, there was loss of signal during the neuromonitoring, and this was improved with adequate resuscitation and pressor therapy. She got extubated at the end of surgery and then went to the neurocritical care service as she was on pressors to maintain a MAP greater than 85. And then on ICU developed worsening shortness of breath, hypoxia, and what looked like pulmonary edema on the chest x-ray with widespread V lines on the chest x-ray. So once again, she had a POCUS study done because we just wanted to figure out why we had suddenly ended up in what looked like pulmonary edema. This is her parasternal long. So do people want to, and sorry, I'll just give you the short axis view. People want to comment on what they're seeing here?
The left ventricle, left atrium appears enlarged, a CVs.
Yeah, absolutely.
That is an over-
I think somebody was saying something and I cut them off. Okay, yeah, so absolutely. So maybe contractility looks fine here of LV and in the long and short axis view, but you're absolutely right. The LA looks really big, you know, and if you compare it to the LVOT outflow tract, it's very broad. So if we're seeing this, then really if we're still worried, then when we're seeing normal LV contractility, the real questions to me are, is the afterload adequate? So has this patient got a normal blood pressure? Well, yes, we were maintaining a MAP of 85 here. And then the next question is, what about the valves? And so to interrogate the valves, you know, you need to put a bit of color over, and you can see torrential MR here in this patient. Let me just play this one as well. So looking in two different views, and you can see massive MR, which would kind of explain the dilated LA, and also why this patient is now suddenly in pulmonary edema. And you know, this patient probably had MR anyway, but then soon as we put the patient on pressors and take them off positive pressure ventilation from the operating room, then suddenly that has now meant that they're in pulmonary edema. And she went on, she actually had a prolapsed mitral valve leaflet, went on to have surgery and did fine from that point of view. So really the learning points here, that a normal or a hyperdynamic LV should be based on a normal blood pressure. And then once that has been ruled out, then really we need to check valves before we can comment on the valves. So we need to put color across the valves. So in summary, I hope I've got you on board to say that POCUS is really a vital part of trauma patient care. And really we should all be able to undertake an EFAR scan, because it really can help differentiate shock even in non-trauma patients, and it's something that we should all be able to do. I obviously haven't gone through the details of how to do these, and I think each of those views is a talk in itself, and hopefully in the future we'll have more on that. I just want to really acknowledge the help of Dr. Sarah Nikravan for all of her teaching. So thank you very much, and I will take questions. I think I've got one.